This non-promotional podcast series is organised and funded by UCB, intended for healthcare professionals in the UK and Ireland.
Welcome to the Let's Talk About Dravet Syndrome podcast series. I'm your host, Mike Taylor. I'm a consultant paediatric neurologist in Leeds Children's Hospital. In this series, we'll share practical input from specialists and real-life stories from patients and their families. This is to bring you closer to this topic, raise awareness, and empower the medical community to work closely with patients and their families to improve outcomes and quality of life. If you've not done so, please hit the subscribe button so you don't miss another episode. And if you love this podcast series, please do me a favor, give us a rating or review on whatever platform you're listening to us on. The reason we need this is the more positive reviews or ratings we get on those platforms, the more this podcast will be shown to those who have never listened to us before. The aim is to improve the lives of people who have Dravet syndrome.
Today's episode, we'll be talking about genetic epilepsy, diagnosis and testing. And we're joined by my colleague, Professor Andreas Brunklaus, consultant paediatric neurologist in Royal Hospital for Children, Glasgow, and honorary professor at the School of Health and Wellbeing, College of Medical, Veterinary and Life Sciences in the University of Glasgow. Thank you for joining me today, Andreas, because you're being a mastermind of quite a lot of the advanced work on SCN1A and Dravet in the UK in the last decade. And it's great having your expertise and being able to pick your brain on this podcast.
Yeah, so thanks, Michael. So it's a real pleasure to be here and very happy to ask any questions you have.
So I think the big question is, we know that 85% of our Dravet patients have an SCN1A mutation. But what are the other genes that you think we should be considering when we have a Dravet phenotype?
So I think that the 85% figure is probably wrong. I think the figure is actually much higher. I think there's this recent work from different groups around the world actually estimating this is closer to 95%. I would argue that actually we have closer to 95% of children will have, with a typical Dravet phenotype, will eventually have an SCN1A variant. I think there's many variants, and I think this is just more limited by the testing abilities. And we really struggle to find deep intronic variants. So there's still variants that are not obvious. And with new testing techniques, I think, that our detection gets better. And I would say that with now modern testing techniques, we should identify at least 95% of these children with typical Dravet presentation as carrying an SCN1A variant. One of the difficulties is that you can get mosaicism. So basically that not all cells in your body are actually affected by this. So you might have a degree of mosaicism that only 20-30% of cells might be affected. And that is not obvious on testing sometimes, and you have to look specifically for that. And you need to have a certain read depth so you can actually detect that. So my advice always is, if you have a typical Dravet presentation, you need to speak to your laboratory and to your geneticist colleagues to say, actually, this is a really typical Dravet presentation. Can we please make sure that we're not missing an SCN1A variant that might be a mosaic variant, or it might be a deep intronic variant, and you might want to go to a whole genome sequencing and really just to test that child with all that we've got available. And I think that's really, really relevant, because if you have a Dravet phenotype and you have an SCN1A variant, then of course, the newer treatments, disease-modifying treatments, the prerequisite for that is that actually you need to carry an SCN1A variant. So I think it's really important not to miss that. Yeah.
So I think one of the things I always think about is that we've also got certain genes that we know have an impact on the SCN1A channel, such as SCN1B. Those are probably account for a degree of them. And then we have conditions like PCDH19 that previously were given a Dravet phenotype diagnosis, but we now recognize as its own distinct developmental and epileptic encephalopathy. I think that's always really important, that probably we know there are many more genes like STXBP1 as well, would have classically maybe been given that Dravet phenotype, and actually we're evolving into that these may have distinct and bespoke epileptic phenotypes.
I would say that once you've satisfied that definitely this is not SCM1A because you really looked at everything very detailed, then I would look for other genes, of course. Yeah, so and PCH19, the GABRA mutations. You have got SCM1B. So all those phenotypes can be similar, but they're not really the same. But particularly if you have a young child and the phenotype hasn't evolved entirely yet, that would be very, very relevant. Yeah. So looking for Dravet mimics, as I would call it, because they're not Dravet syndrome, but they're Dravet mimics, and that would be important to identify.
So one of the biggest things that I think has come out in the last 3 or 4 years, and I think it's really revolutionized practice as a pediatric neurologist on the ground running an epilepsy clinic, has been the impact of the modelers, because which obviously you've had a massive hand in creating, and it's really made it so much easier being able to take that gene mutation, put it through, you've got the kid who's in ICU, you've got the genetic result, and have a very fruitful conversation about what the likely trajectory is. You're able to say, actually, it's a 70, 80, 90% chance of this being a Dravet phenotype. But sometimes the genotype doesn't always correlate. It's a modeler, it's an idea of how it works. So I have a couple of families who have a very guess plus phenotype, who multiple family members have it, but if you put it through the modeler that he did present at 4 months of age, he's doing really well, but it's a 97% chance of having a Dravet phenotype. Do you think that, how do you address that scenario? Do you think it's worth having that early Dravet conversation and talking about how the modeling looks, or do you think it's worth holding back on that?
So I think, the models that we developed really are to guide clinicians, but it should be the clinical phenotype really is the most important. Yeah. So the patient that's in front of you, if you're saying it's a patient coming from a GEPS plus family, where you know that the other family members will have the same variant and are intellectually normal, then of course it's a different discussion. The model is heavily influenced by the age of onset. So if you have an early seizure onset, that will always skew you towards that predicting a high chance of Dravet syndrome, and this is what we understand from looking at hundreds and thousands of patients with either Dravet or GEPS plus. We know that if you have GEPS plus, you present, in principle, you present later, compared to Dravet.
Do you think we get a degree of variability within a family as well? Do you think there's that sort of, you can get the Dravet and the GEPS plus with the single gene mutation, and the variability that we just don't understand why it presents that way?
Yeah, no, absolutely. We see there's a number of, I have those families as well, where you have several individuals carrying exactly the same mutation, but presenting in different ways, also presenting with different degrees of a learning disability, for example. And this is clearly an indication that this is not just monogenic. So there will be modifying genes. There might be other things in the family or the genetic background of that individual that actually makes it more vulnerable compared to other family members. I think what's really important is, and what we understand is that patients should receive the right treatment. So, for example, if you receive contraindicated medication, such as sodium channel blockers, then that will have an impact that wouldn't be good, because that would cause worsening of the disease and would be associated with later worse outcomes. I think that's really important to remember.
Yeah, I think that's one of those things that it almost makes the conversation slightly more difficult whenever you do have that variability in the family history, because everybody might be thinking this is going to be GEPS plus because dad, aunt, uncle have a very similar phenotype and have a very early onset history, and then you've got this kid who is evolving into the classic Dravet phenotype, and you've maybe been falsely reassured yourself that well, it's probably isn't Dravet, they're probably going to go the same route, and then they subtly evolve and you're going, oh no, I'm watching this evolve.
I would probably say, I mean, this is really not a common scenario. Yeah, so I think the more common scenario is that you have a child presenting at 3, 4, 5 months of age, might have a truncating variant, and then that child will still appear developmentally normal to the family in the first year of life, but actually the model can then tell you that actually this child has got a really high chance of about 80-90% of Dravet syndrome. And that really, I think, informs your decision making to the degree that you have, if you have the variant, you've got the age of onset, then you're more confident that, this is probably heading towards a Dravet presentation, meaning that you can actually start with the correct treatments straight away, and I think that will be beneficial for the child and for the family.
And coming to truncating variants, I always think about your paper, I think it was the end of 2023. Are protein truncating variants ubiquitously associated with Dravet, or do we, I sort of already know the answer, it's a bit of a leading question really. Do we think that we can get GET plus or a different phenotype depending on where the truncation occurs?
So I think a truncating mutation basically means it's an abolition of function in that protein. So remember, you've got Dravet syndrome caused by SCM1 mutations in the SCM1A gene and then protein, and you will only produce 50% of your functioning protein and sodium channel. Okay, so if you have a truncating variant, that's basically of your 2 copies that you have, one will be completely destroyed or will not be able to produce protein. So you end up with 50% and with a Dravet phenotype. And what we know is that some missense variants can be milder, and lots of the GET plus variants. And the assumption is that they still produce a protein or a channel that is not so effective, but it's still working. Okay, so can you imagine a situation where you have a truncating variant where you still have a functional protein? And we found that in very rare cases that can be the case, and that is particularly if the truncating mutation is right at the very end of the gene. Yeah, and the very end of the protein, meaning it doesn't lead to the destruction of the entire protein. Yeah, but the protein, the length is about 2,000 amino acids, and really, if you have a truncating variant from 1,950 onwards, yeah, so it's really in the last 50 to 100 amino acids, but that's rare. That's rare, but we've seen it. Yeah, but it's a minority. Normally, you would expect a truncating to really lead to a complete abolition of protein and channel function.
So I'd like to mention, and again, it's another one of your papers. I think, as I said, you have been a workhorse of doing most of the work in SCM1A. Whenever I think about big papers, the gain of function variant and the population, how do they differ in how they present and in how we can treat them?
Yeah, so I think this was really quite an important discovery that a few years ago we really came across these very unusual presentations of young children with SCM1A mutations that actually didn't present like Dravet patients. And I think the first who described it was Ingrid Scheffer and Lynette Sudler. They had a group of about 6 children they presented, and they presented with what we call a very prominent movement disorder. So these were young infants and children who had very early onset seizures, but also a movement disorder, meaning that constant choreiform dystonic movements, and that was really unusual. So you normally wouldn't see that in Dravet syndrome, and those variants have been functionally characterized as showing a gain of function in the voltage-gated sodium channel. And then we came across many other patients that presented really at birth or in utero at birth with contractures, so stiffening of the joints. Then later on, these dyskinetic choreiform movements. And what we identified was that actually all these patients were very similar in presentation and very un-Dravet-like, and all carried actually gain of function SCM1A mutations. And that's very relevant because if you have a gain of function in the sodium channel, actually in that scenario, you want to use a sodium channel blocker to actually block the gain of function. So those kids actually got better with sodium channel blockers. I've had a couple of those children myself where really we discovered way back the SM1A mutation and were very hesitant, of course, wouldn't start sodium channel blockers, but actually with the revelation that this is a different phenotype, it's a different disease. And what's important here, I think the main difference is that they present far earlier. So they present in the first days and weeks of life. Yeah, you would never see this in Dravet syndrome. Yeah, then their seizure types are very different. You can get epileptic spasms, you can get tonic reflex seizures, you can get a non-convulsive status epilepticus, you get this movement disorder, you've got, so all these features are really quite different to a classical Dravet presentation. And in those individuals, you should consider whether sodium channel blockers might be indicated.
I think it's one of the most gratifying moments of BPNA a couple of years ago was one of my colleagues was telling me about their kid who had presented a few weeks of age and they've got this SCM1A mutation. And actually I was able to sort of pull out your paper and say, actually, this is going to be gain of function. You need to think about you start your sodium channel blocker. And actually they contacted me a few months later to say, actually, when their genetics looked at everything, it was actually gain of function. And the kid had got better on a sodium channel blocker. So that was a very gratifying moment, being able to take that and put it in the real world device with benefit on the patient. And that's great that we're seeing things, but I think it puts an onus on us as clinicians to think more deeply about the genetic mutation that we're seeing. And I think it comes back to what you said, it's all about the child in front of you. Does that story add up to Dravet? Or is there a different element to their presentation?
I would say the key really is the phenotype. Yeah, it's how the child presents. Is it a classical Dravet presentation, or is there something different? And would this be in keeping with a gain of function presentation? Yeah, and that's very relevant. There's some tools as well that you can use to predict whether it's gain or loss of function, and that's really advanced as well. I use that all the time, and it's very helpful. But often these tools, the way they're conceived and designed, they take into account what has been previously described in the literature about certain cases, and sometimes that description might be wrong. And so the prediction you get sometimes from some of these other tools, whether it's gain or loss of function, might not always be accurate. And for me, the phenotype and patient in front of me always tops any prediction tool. Yeah, so I think the patient in front of you really is the expression of that disease in that individual. So I think that clinical phenotype is the most important piece of information, and that's actually the easiest to assess for all of us. Yeah, so this is that's really important to remember. That don't be swayed by a prediction model when actually your patient tells you something different.
So this brings me very nicely to an area that once again, I'm very, very privileged to be part of this, is the Horizon study. So can you tell the audience a little bit about the Horizon study for anybody who mightn't have heard of it?
No, thank you for asking that, Micheal. So the SCM1A Horizon study is a natural history of SCM1A related disorders in the United Kingdom. So what we've seen over the last 2 decades, really an explosion of knowledge, of genetic knowledge, and we've learned so much more about the genes and how to interpret them. However, we haven't made that progress with regards to describing the phenotypes of SCM1A related disorders in much more detail. Yeah, and I think to make really advances of genotype phenotype associations going forward, we really need that really good phenotypical description, and that means, for example, at what age do children present with their seizures? Which medications do they respond to? Because we know there's still children who might respond to one medication with Dravet syndrome, but they might not respond to a different medication. And we don't understand why that is. We don't know how every child will develop, actually. Will all of them develop the same degree of learning disability or are there patients who develop more autistic features? Are there patients who develop more ADHD type features? And why is that? So at the moment, we have no idea to answer those questions. And by performing this natural history study, we're actually enrolling every patient with an SCM1A mutation in the United Kingdom into an ongoing longitudinal study where we actually collect all this information systematically. And we've done it in a way in collaboration with all the child neurologists like yourself and colleagues across the UK, where we actually came together to design the study together, to actually think about what would be a sensible way, what is the sensible information that we require going forward, and that can be easily collected in our clinics going forward. And this will allow us to really address all the main topics that are related to this disorder. And for example, we can actually have the same, or we can aim to have the same standard of care across all the UK centres and across the entire UK. And we've seen in other diseases, for example, in cancer care or in neuromuscular care, initiatives like this have been really, really helpful because they provided us with so much more knowledge, and we've been able to improve our treatment approaches and to improve research efforts, but also we were able to improve standards of care and ultimately outcomes for patients. Yeah, so this is really, really important. And by doing this study, the SCM1A Horizon study, coming together as a network and group of clinicians from across the UK, that's really important. And I'm pleased to say we've had a fantastic response. The study went live in autumn 2023. So last year, 2024, we expanded to over 17 sites all over the UK, and we've already recruited over 120 patients. So it's absolutely fantastic. So we've had lots of engagement from the community. The families have been excellent. And so we've had lots and lots of engagement. It also means that all the families are engaged with the charity, with Dravet Syndrome UK as well. So they're better informed. They know about the newest treatments that are becoming available. All that is really beneficial for our patients and to provide them with better care going forward. And our intention really is to continue this longitudinally and to collect data longitudinally. And this will allow us also to give, for example, this data back to our clinicians. So when you're, for example, seeing a patient and you're recruiting them into the Horizon study over years, you will actually be able to see very nicely how that patient has done over time. You will know what the seizures have been doing over time, which medications you've been giving, how many emergency visits they might have had, and all that will help you to manage your patient and ultimately will lead to improved patient care. I think that's really, really important.
I think that comes to what's the biggest practical gain is improving patient care. But I wonder, do you think with the advent of the newer treatments or better pickup rates, do you think the natural history study now is different than it would have been 20 years ago? And potentially as we see newer treatments, the genetic technology coming through, do you think it'll be different than what we'll see when we do this in 20 years' time at the end of our careers and we're sort of seeing out what the advances have brought?
Yes, I mean, we would all hope that. So you would hope that with years passing, that we actually are able to implement the scientific knowledge into our treatments and we can improve outcomes. So one aspect that we clearly can see, and when I did my original Dravet research in 2010, when we then looked at large cohorts across the UK, and we had many more patients, for example, that had been exposed to sodium channel blockers in the past. And now we see that's only happens very rarely. Yeah. So I think so we can see that certain medications might have been given in the past that either might have caused harm or might not have been so effective, and now this has changed. Yeah, so we can see that there's been a change in practice, and there's different medications being used, I think, which has been helpful. And what you would hope that with ongoing data collection here, what is important is that will inform our treatment going forward. And I would hope that in 10 years, 20 years time, we actually will have even better outcomes for our patients and families. And this is one of the important aspects also of the natural history study, to actually shed light on our current practices and whether those are effective, or whether we need a change of practice, because we have certain medications that might be given in emergency situations. And the question always was, do they actually make matters worse or they don't? And those are really questions that are unanswered. And the natural history will be, I think, very valuable and informative to answer those questions going forward.
So I want to think about genetic epilepsies as a whole. And I know that the team in Glasgow have, in my opinion, been at the forefront of the world's research on genetic epilepsies. So these are more broad questions that we as pediatric neurologists, pediatricians with an interest in neurology and epilepsy should think about. Who do you test and when?
Yeah, so I think what we now understand is that the majority of the early onset epilepsies will have a genetic basis. And there's been a study done by my colleague, Joe Simmons and Samir Zuberi, looking at children presenting with epilepsy in the first 3 years of life, and the genetic testing transformed the diagnostic rates in those children prospectively. So it's been really, really encouraging to see that actually the younger the child, if you've got an infant presenting at less than 1 year of age with epilepsy, then genetic testing really should be on your mind. In particular, if you have children presenting in the first months of life. Yeah, so having genetic testing, particularly in very young children, is really, really important. And those children that present as a neonate or in the first few months of life, that's very relevant. And for Dravet syndrome, of course, presenting with early hemiclonic prolonged seizures, that really should prompt you to test for Dravet syndrome quite early on, because the main differential here would be an infant or a child with febrile seizures, which are not, are not as significant. However, they would normally present slightly later, and they wouldn't necessarily be so prolonged. They wouldn't be recurrent. So there's clearly distinctions here in terms of presentation. If you have a young infant, less than 6 months, presenting with a prolonged hemiclonic status, they need to be tested for an SCN1A variant. I think that's really, really important. And neonates as well. So if you have very young infants, they need to be tested, because your result actually might then indicate, oh, this child has, for example, an SCN2A mutation, or they should be starting sodium channel blockers, or genetic testing in this age group will actually influence your treatment choice and inform the best practice treatment for that infant.
I think it also comes into the paper done by Amy Micheal last year, which shows the rapid testing and how the impact of getting that early will hopefully translate into also clinically appropriate treatments in practice. I think it sort of really has been very, very useful. Certainly in England, we've been able to get rapid genetics on the under ones, which means that we're not waiting 6 months a year for a gene, where we are getting them back in these scenarios within 2-3 weeks. And often we can initiate appropriate treatments, whether that be treatments directed towards Dravet syndrome, or if it's one of the SCN2A variants or something that's maybe amenable to a sodium channel blocker, we're actually able to get these children on the appropriate treatment at the appropriate time. And I think that's a very exciting phase to be in as a clinician, especially one who's got an interest in the genetic epilepsies. So how do you overcome the parental fear of genetics? Because parents are always worried. I think my experience has been they always feel like we're going to find something that they'll blame themselves that they've given their child. How do you work with parents in your clinical capacity when dealing with approaching genetic testing?
Yeah, so I think there's often lots of preconceptions for families what genetic actually means. Yeah, and most families actually assume this, it means inherited. But of course, the first thing I tell families is, well, it doesn't mean that. So most of the variants we find are not inherited. They're actually de novo. And they're just a chance finding. And that's the first thing I tell them. So I tell them actually, ask them, what is your understanding of genetics? And then I explain that actually, that most of the things we're looking for here are likely to be de novo, so they would have arisen just in the child at the point of conception, and they wouldn't be inherited from the parents. Yeah. So I think and that really reassures the families. And what we really find is that and we've done some research on this, having performed genetic testing and being able to give an answer to a problem is very beneficial. Yeah, it allows you to not only to treat appropriately, but also to give prognosis. And also many families would have blamed themselves for years with regards to the disease of their child. And actually knowing that this is really a chance finding and wasn't their fault is highly significant and relieves their burden that they would have perceived. We've received really, really nice testimonies from families where they've been describing how they've been blaming themselves for years, and having had a genetic diagnosis and knowing that this wasn't their fault was really like a huge weight being lifted off their backs. And it's been very, very relevant. So I think genetic testing has really transformed the way we can perform diagnostics and how we can now treat our patients. And most families really understand that if it's explained in the right way.
And I think it comes down to a very simple thing as well. Siblings may not want to have their own children because they don't know if this is something that they carry or a gene that might turn up again. And their own childhood has been influenced by their sibling with a profound developmental epileptic encephalopathy, and they might not want to be the parent to that child because they've seen what that happens. So I think having that also offers an additional layer of reassurance, or it may inform their choices if they're going to have children about pre-implantation genetic testing or appropriate genetic counselling. But this brings me to a situation that I think we encounter very frequently. I just think about whenever I first started training, and we had the 90 gene panel, and it was great. Thought, how fantastic is this? We can test for all these genes for epilepsy. And I think my last count was 950 something. I'm losing track, and I imagine within the next 10 years, we'll hit 1,800 very easily. But what's your approach when the genetics come back negative?
So a negative genetic test will only mean it is negative in that moment. I always tell our families that 10 years ago, we would have done testing and only 10% of tests would have been positive. Now, at least 50% might be positive. And the pickup rate increases. And I think if we haven't found anything on this occasion, it doesn't mean that on retesting, particularly with the whole exome and whole genome sequencing, so you can re-look at a data set and you can then reanalyze that in years to come, and you might find indeed a variant or an explanation. But of course, you always have to be critical. If the testing comes back negative, you have to then really reflect on what testing was performed, what level of certainty you have. Do you need to look at specific aspects? Was it an exome? Was it a genome? If it's an exome, they would have looked at a certain panel of genes. So are there other clues in the history of the child that actually makes you think, actually, we should look at different panels, or we might consider other genes? So I think this is a dynamic process where you have to, look at your patient, see what is likely, then reflect on the genetic testing results, and then take a step forward to say, actually have a discussion. I think MDT discussions are really important. So have a good MDT with your geneticist, your genetic scientist, discuss the results, and then reflect on whether other tests might be indicated. And then clearly with new advances and discoveries coming through over years to come, this can be assessed again.
I think it's I'm very similarly how I approach that situation is I do say the families, especially about very, very strong conviction that this is going to be a genetic epilepsy. We will go back in 5 years' time. I'm going to ask them to look at the data set again. Do not worry, this is a moment in time. And I think that's really, really important that families know it is a dynamic process and things will evolve. And it may be that we get more clues into that evolving phenotype. But I think it comes back to what we've said throughout the entire of this podcast, is that actually this is informed by the child in front of you. First and foremost, it's all about clinical acumen and looking at that child and seeing, do they tell you their story and does that story match up? And possibly nowhere more important than Dravet syndrome itself. Well, that's it for this episode. If you love this episode, please share it with your appropriate colleagues. The only way this podcast is going to get out there is by you lovely people sharing it. So I would appreciate it if you could. And if you want to stay with me and learn a little bit more about Dravet syndrome, then please join me on the next episode. For now, I'll say goodbye and see you next time.